Hello everyone, today we're going to take a look at this case also adapted from Radiopedia. As you can see the demographics, it is an 8-year-old male patient presenting with chronic atraumatic left arm pain. So first of all, we can analyze the presentation. As you can see, the age is really important. This is an skeletally immature patient which is relatively young, below 10 years old. Okay, so this is a first important clue. Another important clue is that you can see that the symptom is chronic without any previous trauma. Okay, sometimes the traumatic event may not be remembered by patients, especially very young patients. However, you need to also take note of any possibility of neoplastic causes. Okay, usually they will give rise to some pain, especially night pain. Okay, which is quite alarming and red flag in terms of clinical presentation. Okay, so take note of these 2 points first, and then we are going to take a look at this left humerus radiograph. Okay, so if you can analyze more in detail, okay, you can already spot that there is increase in lucency. There is some ill-defined erosions involving the proximal left humerus, including the proximal shaft region and also the metaphysis region. Okay, so actually how do we really assess that? Because you do not see there is significant bone loss, but there is something quite strange in appearance. So let me try to break it down into minor detail and tell you how you can assess that. Okay, so first of all, you can see that this is the normal bone cortex. Okay, and the cortex, actually there are 3 components. One, which is the endosteum. Okay, and then also the cortex has its own thickness. Okay, and eventually you will have a periosteum. Okay, and then outside the bone, okay, we also have some soft tissue, but usually you will appreciate this delicate fat plane before we have the muscle. Okay, and you see this usual muscle, and there is a little bit fat plane inside. Okay, so this is what we expect to see normally for majority of the bone. Of course, we have different anatomy in various parts of our body, but this is the major first principle that you may use in other body parts as well. Okay, so let's continue. Okay, we try to zoom in further like this, and then you can appreciate that the cortex will gradually taper down from the diaphyseal region and then towards the metaphyseal region. So what I would expect is that there will be much smoother periosteal lining and also endosteal lining, and then there will be a gradual tapering down in the thickness like this. Actually, you do not see the normal cortical lining. Both the endosteal and the periosteal lining are actually very fuzzy, very irregular, so it must be something abnormal. Do you see additional opacity, which is at the expected position of the periosteal layer? So basically, this is what we call the Codman's triangle. Okay, so what does that mean? Because if this is a bone lesion located within the intramedullary cavity, okay, so these are the bone cortex. They are trying to invade firstly through the endosteal layer, then the cortex, then the periosteum. So if the lesion now grows here like this, okay, the periosteal lining will try to control it by overlying itself over this lesion and then lay down a layer of bone. Okay, try to confine this lesion. Okay, however, if this is a really aggressive lesion, that means it has a quite rapid growth rate, then the confinement will fail. So you will see that the periosteum will get pierced through this area and then only form a small triangular shaped area. So you would notice that there must be some sort of soft tissue adjacent to that. This is the margin of this extraosseous soft tissue. And then we're going to notice some laminated kind of periosteal reaction. This is a very important clue because this is rather classic for Ewing sarcoma. Sometimes in examination setting, they will ask you, okay, what kind of aggressive periosteal reaction will you expect for Ewing sarcoma and also osteosarcoma? Actually, there is no black and white answer, but what I will recommend you to answer is that because Ewing sarcoma, they are more permeative, more infiltrative. Usually they will not have very big bone erosion, but they will try to invaginate through tiny holes of the cortex. So they will have a very sizable extraosseous soft tissue component without having a very significant bony destruction of the parent bone. Okay, so for such a broad extraosseous soft tissue component, you expect to see a broader layering of periosteal reaction, which is looking like this, okay, which is more classic, okay. However, for osteosarcoma, they tend to have a more significant bone destruction of a focal point and then extending through that part, and then you expect to see some common triangle there, okay. So they're not black and white, they can exchange as you see. Common triangle is also seen in this case of a Ewing sarcoma, but this is the more classical scenario, okay. And then we know that basically the trabeculae here is sort of eroded, permeative appearance, and then we have some destruction of the cortex with some laminated aggressive periosteal reaction. So how can we deduce whether there is extraosseous soft tissue components? This is extremely important clue for Ewing sarcoma, as I've just mentioned. Should be very sizable one, okay? Before we can judge that, basically we need to know some anatomy of the soft tissue around the region that we are actually assessing. For example, just now I tell you that there is usual fat plane outside the periosteum, but you do not see that here, right? There is a loss of the fat plane, and then you start to realize that actually the entire shaded area is an extraosseous soft tissue component, okay? And also, I will tell you that, okay, this is the cross-section of the deltoid muscle, which is a thin, broad muscle like here, but you do not expect to see such an increased opacity underneath it, okay? Either there is fluid at the bursa underneath the deltoid, or it may be some soft tissue component which elevates this deltoid muscle, okay? So we expect to see there is at least this area are the quite sizable extraosseous soft tissue component, while it is relatively significant with respect to the extent or severity of the bony destruction of the proximal humerus. So combining with the age, it is very likely to be Ewing sarcoma, okay? So what else do we need to do? We need to try our best. I know that radiography not be a very suitable modality to fully assess for other related lesions, especially those skip lesions. Better use MRI. However, we need to try our best. Okay, for example, is there any erosion to the physis? Usually, there is a well-demarcated cortical line, okay, outlining the physis. Where there is involvement of the physis, involvement of the epiphysis, as well as the joints, okay, which another important clue for us. And also, we always mention that we need to assess one joint above and also below, okay, because this can involve other longitudinal length of the same bone, but obviously the elbow joints appears unremarkable. So have a quick recap of what we've mentioned in the case of supracondylar fracture. The age is important, okay, not just skeletally immature, but the approximate age, which is around 7 to 8 years old, should be less than 10. So the possibility of osteosarcoma is less in this case. So you see the importance of the exact age whenever you have a skeletally immature patient involving the elbow, okay? So how about the lung? The lung is not very well included. However, you still need to try your best to look for any lung metastasis, which is common, okay, for sarcoma, okay. And then we see another view, and then try to appreciate the periosteal reaction. Sometimes many of the trainees will confuse, okay, so actually what's the point of seeing another similar image? Okay, they appears to be similar, I would say, okay, but I will explain like this, okay. So this is the cross section of the bone of the humerus, for example, the bone lesion inside, okay. Just now maybe we are going to take a look at these two aspects, okay, of the cortex, but sometimes we do not see the classical periosteal reaction here, but rather they may appear in other points, for example, as the anterior aspect and also the posterior aspect like this. So we need to have another view so that these two portions will become in profile, just like here. For example, you see better laminated periosteal reaction in this view. Okay, so we are actually visualizing the circumference of the bone in different angle, at least in two planes, orthogonal in nature. Okay. And then this one, I think the author want to zoom it in so that we can appreciate for the laminated periosteal reaction, which is more classical, okay, for the Ewing sarcoma. And try always your best, okay, to look at the orthogonal plane, not just for the periosteal reaction, but any subtle pathological fracture, okay. So in this case, we learned that firstly, how we can delineate for an aggressive bone lesion, and then also what types of aggressive periosteal reaction is usually associated with Ewing sarcoma, and then also try to assess the extent, especially the local extent, involving the same bone, including one joint above and one joint below. And then, if there is included lung, try to see any lung metastasis. And then always use orthogonal planes to ensure that you have a better delineation of the periosteal reaction, bone destruction, as well as any pathological fracture.